Perfect.
Awesome. Okay, so my name is Rachel Edasami. I'm from Epilepsy Support Network of Orange County. We are great friends with Sophie's Journey, of course, the presenting organization for this expo, and they have asked us to help introduce and kind of host with some of our local doctors. And we are very lucky that we get to work with amazing doctors like Dr. Romain at CHOC Hospital. He is a neuropsychologist, and really we work with a lot of the same individuals. A little bit of what we do quickly is we're a nonprofit. We are local to Orange County, but kind of a blessing in disguise from this crazy year is all of our programs have gone virtual, so they are accessible to anyone. So we have lots of different, every single month we have a doctor come and speak, and that has included in the past Dr. Romain and his colleagues. And so I'm excited to hear what Dr. Romain, I specifically asked if I could host this one because I'm excited to hear what he has to share with us today. So I will put a little information about our organization in the chat section so that's accessible. But if you have questions, and correct me if I'm wrong, Dr. Romain, how you want to run this, but if you want to throw those questions in the chat section, I can kind of pitch them toward the end of your prepared talk. Is that okay?
Yeah, whatever's most effective and convenient. Probably towards the end though, yeah, because I only have a short PowerPoint here for you.
Okay, perfect. Okay, I will go ahead and we can run it like that. Thank you so much, Dr. Romain.
So again, yeah, my name is Jonathan Romain, a neuropsychologist here at CHOC. I've been here almost 8 years now. I was previously at Medical College of Wisconsin, Children's Hospital of Wisconsin, and I was part of the epilepsy program there. And here at CHOC, I'm part of the epilepsy program as well. I do a lot of the evaluations for our pre-surgical epilepsy kiddos, as well as seeing other patients from neurology and actually a variety of other specialties. So I was asked to talk a little bit about epilepsy and learning, and as you can imagine, it's a pretty vast topic. So I just have a couple PowerPoint slides to kind of orient you guys to that, and then happy to have a discussion. I'll say this probably a few times. Epilepsy is kind of like snowflakes. They're so different. Every disorder is going to be different. You can have two children who have actually the same type of epilepsy, and they can have a very different presentation. So when we have a discussion, try to bear that in mind, because I'd like to be maximally impactful for everyone. So if it's a specific question about a specific finite little thing that your child might have, it might be difficult to talk about over this larger Zoom meeting. So anyway, let me see if I can share the screen here. Everyone see that? Fantastic. Okay, so again, we're going to talk a little bit about epilepsy and learning. Pretty much every slide I have here could be its own separate PowerPoint. So we're going to jam through things pretty quickly here. So I have an outline. I want to talk a little bit about what is a neuropsychologist. I'm sure many of you have heard of neuropsychology, but several of you probably have not. So I'll talk about a little bit about what we do in terms of our evaluations. And then as it relates to learning and epilepsy, we'll just chat a little bit about some of the types of epilepsies, just to give you a broad picture of this is a huge spectrum disorder. And then we'll talk specific about learning challenges associated with epilepsy. And then I'll give kind of a broad overview about school intervention and considerations. And then certainly we'll have some time for discussion. So neuropsychology is a PhD or a PsyD in clinical psychology. We have graduate level coursework and subsequent fellowship training in neuropsychology. So we spend a lot of time doing coursework on brain and behavior relationships, basic neurosciences, those kinds of things. And we seek an internship that aligns with neuropsychology and with oftentimes rehabilitation psychology. And we also have fellowship training. Fellowship training is usually a 2-year fellowship, specifically in neuropsychology or pediatric neuropsychology. And we also have board certification as well. So essentially, neuropsychology is a study of brain behavior relationships. We essentially use standardized paper pencil tests, so nothing invasive. I always tell my kiddos before they get started working with me, no shots, no electrodes, no pokes, nothing like that. Just to kind of allay some of the anxiety or worry or apprehension. What we do is we look at a global ability. So global ability can be defined as intelligence, I kind of don't like to use the term intelligence so much, especially when I'm talking about learning disabilities or learning strategies and learning styles, because intelligence is a broad construct, and so it doesn't really tell all of the story. But again, global ability would be things like verbal reasoning, visual spatial skills, working memory, which is keeping information in mind, and processing speed, how quickly one can process information. We also test areas of attention. We look at auditory attention and visual attention, and impulsivity and distractibility, again, on formal measures. We also look at a broad concept called executive functions. Executive functions are, you have your global ability. Now, how do you use that global ability to solve novel problems? How do you use that ability to figure out that a strategy that you're trying to use is no longer working, and how do you kind of switch it so you can do a more effective strategy or use a more effective strategy? Executive functions, I'll just say as a sidebar, they're definitely present in even younger children. You can see this in 3-year-olds and 4-year-olds making decisions and those kinds of things. It's just a little bit harder to assess in younger kiddos in terms of formal assessment. And then we also look at language functions, so expressive and receptive language. We look at naming and those kinds of things. We also assess for memory, visual memory, verbal memory, or auditory memory, like list learning tasks, story memories, and all those kinds of things. We also assess for academic skills and adaptive skills. So that would be like daily living, so safety, coping skills, social skills, those kinds of things. And then we also assess emotional and behavioral functioning. So that's what we do in a nutshell. Again, just to give a broad overview, this is what we're dealing with when we think of epilepsy and learning. We have our focal onset epilepsies, we have our generalized onset epilepsies, and our unknown onset, and they have, they're broken down further into simple partials and complex partials and those kinds of things. And then we have our epilepsy syndrome. So most of these I'm familiar with. I'll admit there's a couple that I have never seen before myself, TBCK being one of them, but maybe it's short for a longer syndrome. And so there's a wide variety of epilepsy syndromes, many of which can result in learning challenges. And I'll have some statistics in a second about that. And we have other components here. We have genetic factors. We have acquired issues. We have structural issues, dysplasias, and those kinds of things. And these are all potential causes of epilepsy. So again, when we think of epilepsy, it is a really broad group. And yes, you can see learning challenges in many kiddos who have epilepsy, upwards of 40%, but it's going to be pretty variable depending on the nature of the epilepsy that they have. Also, we have anti-epileptic medications. They work in a variety of ways. Broadly speaking, they have ones that are activating, and then they have ones that are more kind of a deactivating, and then there's also different channel blockers and all those kinds of things. Not the time to go into it. All this to say, there's a lot of different anti-epileptic medications, and they do have different effects. We're dealing here with a disorder, epilepsy, that affects the brain, and the brain again is responsible for learning and processing. So when we're trying to treat the brain, we're using medications that can also affect things. Now, sometimes medication actually can make things much clearer, especially if you have a kiddo who's got uncontrolled epilepsy, and all of a sudden they have kind of a clearer profile because of their anti-epileptic medication. Their learning ability can actually improve. So anti-epileptic medications need to be considered in the broader picture of learning challenges and also learning successes. And then we also see with many kiddos who are on anti-epileptic medication, we see combination therapy or multiple medications. So there's a lot of good research out there on the different medications by themselves, so that you can find several studies on valproate, you can find several studies on Keppra and the impact on learning and or emotional functioning and behavior. But when we get into kiddos who are on several medications, it's going to be a lot harder to find a specific research article that identifies, a sample of 350 kids who are all on a combination of X, Y, and Z. So that, again, the anti-epileptic medication is another component that makes makes for the diversity that we see in epilepsy. Then we have brain regions. This is just kind of a quick picture of just of the left hemisphere of the different gyri and their names and labels. We have kids who have epilepsy that affects the temporal lobe. Sometimes it can be more mesial, sometimes it can be inferior, superior. Again, every situation is different. And in kids, it's a little bit more subtle, but a anterior superior temporal gyrus epilepsy might look different than a mesial temporal epilepsy. And so, and the same holds true for this region right here. This is the frontal lobe, and the frontal lobe is responsible for so many things, including that we mentioned a second ago, executive functions, things like attention, those kinds of things. So planning, inhibitory control, those kinds of things. And so you can have a seizure or seizures or epilepsy that's impacting a portion of the frontal lobe or the temporal lobe. And again, it can have a different presentation when we're considering how a child thinks, learns, and processes information. So this is just another example of that. So we have our, and again, this is very basic here, but we have our attention and planning and decision-making kind of up here that actually even extends even more posterior. And then we have our movement and sensation and those kinds of things. And so the location of where an epilepsy can be occurring, especially in our focal epilepsy kiddos, can really dictate how they present from a learning and processing standpoint. So again, I like to look at epilepsy as a, from a multifactorial lens or model. So if I have a kiddo who comes into my clinic, I want to, who has some learning challenges, I want to know a variety of different pieces of information. Because as I said at the outset, epilepsy is like snowflakes. I mean, everyone is different. Every situation is going to be different. So what we can do, though, is we can use a variety of different variables to kind of help guide us to what we may expect or what the literature says. But at the end of the day, it's evaluating every kid as an individual. So the things I like to consider as it relates to epilepsy and the severity or the potential severity of learning struggles or intellectual disability, those kinds of things, are age of onset. Was this very shortly after birth? Was this an onset that occurred, a few months before I had seen the child? The number of seizures, episodes of status epilepticus, so those are prolonged seizure events or cycles of seizures that do not remit. They can be associated with learning challenges and certainly intellectual issues. Is there a underlying lesion or a genetic or neurometabolic or some other type of condition that's causing the epilepsy? Because again, that can have a lot of that can lead to a lot of variability. And we talked just a second ago about medications that are potentially impacted or impacting functioning. And then are there secondary processes? So is the epilepsy causing something else, or is the medication causing something else? Is there another associated neurological, metabolic, some other type of issue that's also affecting the child? And then, of course, we want to consider things like psychosocial factors. We know that kiddos with epilepsy are at greater risk for mood issues and anxiety and those kinds of things. And so what psychosocial factors can play into the learning environment or the ability to learn over time? And of course, especially with our kids who have uncontrolled epilepsy that I see pretty regularly, we have a lot of school absences. Kiddos who are on long-term epilepsy monitoring for a week. And prior to that, they were having multiple seizures and they were missing school for a long periods of time. And of course, that type of disruption can certainly impact learning over time. Okay, so I want to really separate out here. The first is the concept of intellectual disability. So intellectual disability is basically a categorical designation where you have a normal distribution in the population of, say, a random sample of 100 kids. The middle ground would be the 50th percentile. The 99th percentile would be at the upper tail of a normal curve. And then at the lower end of that tail, we have our first, second, third, fourth, and fifth percentiles. And those would constitute something like an intellectual disability. So defined intellectual disability is global abilities or intelligence scores that are below a certain percentile cutoff, and a commensurate difficulty with daily living skills or adaptive functioning. So communication skill impairment or social skill impairment, daily living skills, those kinds of things. We know also that most people with epilepsy do not have an intellectual disability, but roughly 30% of people with intellectual disabilities have epilepsy. So there definitely is a relationship there. We also see just a couple other statistics. There are certain types of syndromes that are more in line with intellectual disability than others. So infantile spasms being 80%, Lennox-Gastaut being fairly commonly associated with intellectual disability, I should say. And then we also need to bear in mind that kiddos who do have epilepsy and uncontrolled epilepsy are at risk for cognitive declines over time. And that's one thing that we want to be very mindful of, especially in the intractable kids that I see, those kiddos who have uncontrolled epilepsy. We really want to monitor them over time because they're at risk for having some cognitive loss. And I often tell parents that that one thing that makes epilepsy particularly challenging is this is a syndrome where you can see changes or loss of function over time. Some of the other kids that we work with who have had, say, for example, a traumatic brain injury, there is an impact to thinking, learning, and processing. But then there's a recovery phase, and there's improvement, and there's changes, and usually they're favorable changes. Sometimes there's plateauing, but more often than not, especially in working with kiddos, and with traumatic brain injury, there's improvement over time. And yes, you can see improvement over time with epilepsy, but if you have uncontrolled epilepsy, more often than not, you're going to see the potential for cognitive decline. And so sometimes you have a kid who is, functioning in a more successful way, who develops an intellectual disability or falls lower into the ID range over time because of the uncontrolled epilepsy or things related to that. So the difference, though, is that a learning disability has built into it the concept that global abilities or intellectual ability is broadly within the average range, low average range to high average range to well above average range. So what it's saying is that a child who is, say, a 15-year-old child who's functioning at an 18-month-old level doesn't really have a learning disability in reading. Their ability in reading is commensurate with their overall abilities or skill set. So again, there's a distinction between intellectual ability or intellectual disability and learning disability. Learning disability is a specific or defined area of weakness in a particular aspect of school functioning that's impacting the child differentially. So you can have a kiddo who has a developmental reading disability or something like dyslexia. And so if you have a child who is, say, functioning broadly in the average range in other areas or excels in math, but they have major reading problems, that would signify a reading disability. So we know that a large number of kids who have epilepsy have at least one learning disability. We see reading disorder or developmental dyslexia, 13%. These are, you can grab an article here or there, and one's going to say 13%, and another one's going to say 18%, and yet another one just that I read yesterday said 17.68%. And so, but the general idea is that, at least a tenth of kids with epilepsy will have some type of reading disability. We also see mathematics disorders slightly more common, and then disorders of written expression, so writing. I will say anecdotally in my clinical practice, I see lots of concerns for writing disorders. And the reason why that tends to be is because writing is kind of the final frontier in school. You have to have good attention skills. So you have to kind of be able to pay attention to kind of what you're trying to write and where you are when you're writing a paragraph. And you have to have good language skills. You have to understand what the question is that you're being asked to write about. Then you have to be able to use those language skills that you have in order to come up with thoughts and ideas to write down. And then you have to use executive functions to be able to organize your thoughts and ideas so that you can make it clearer or understandable for the listener. And you also have to have fine motor skills. And so if you have a problem in any one of those areas, you can see how you can you can struggle with aspects of writing. So again, I see writing issues very commonly in my clinical practice. And usually what I try to do, or most neuropsychologists try to do, is we try to identify what are the contributing factors to why a child is writing or has problems with writing. And we know that a slightly greater number of kiddos who have drug-resistant epilepsy require special education support in the school. So more often than not, we see that there is some type of learning challenge, and again, 30% require specialized support. I will group here, just for the sake of time and interest today, ADHD. ADHD is not really a learning disability per se, but it can certainly contribute to learning disabilities. And there's often comorbidities, meaning that when I see kids who have developmental reading disability or some other type of learning disorder, often they have a similar type of pattern with ADHD or things that are related to ADD. They tend to co-occur together. So ADHD has a prevalence of 7 to 9% in the general population. And in our epilepsy patients, we see it 20 to 40%. So a little bit more about ADHD and epilepsy. There is a potential for a common genetic link between the two. So again, that raises the prevalence a bit. There's often a common neurological pathways, for example, the frontal lobes. I would also argue that attention is, while attention is largely centered in the frontal lobe, we see attention being manifested in the entire brain. So the entire brain is actually responsible for attention, even though the vast majority of attention and higher order cognitive processes are in the frontal lobe, and even in the cerebellum to a degree. We see that attention is impacted within the entire brain. So if you have a kiddo who has a parietal lobe epilepsy, an occipital lobe epilepsy, temporal or frontal lobe epilepsy, because their brain is being affected, the attention pathway or the attention system can also be disrupted. So even if we don't see ADHD per se, we often see attention issues in kids who have epilepsy. And then, as I mentioned earlier, we have cognitive changes as a result of uncontrolled seizures. So if we know that uncontrolled seizures can cause problems with cognition, and we know that attention is a sensitive pathway in the brain, it makes sense then that uncontrolled seizures can result in more attention problems or things like ADHD. And then we have subclinical epileptiform discharges. So kids who don't have active seizures, but they have a funky rhythm in their brain, so to speak, can also impact their ability to pay attention and focus in the classroom. And then there's the direct effect of anti-epileptic drugs. Excuse me. So epilepsy and ADHD, why would I diagnose the two? Isn't one diagnosis enough? Well, if we identify a second diagnosis that does indeed exist, that can lead to better and more effective treatment strategies. There are also medications and therapies that are proven to work for multiple diagnoses. And then a clear second diagnosis can help teachers manage complex behaviors and develop more appropriate school supports. So not every teacher is familiar with epilepsy, but most teachers are familiar with attention problems or ADHD. So sometimes using that label, again, appropriately using that label, can provide some clarity for the school and guide treatments and supports. And then, of course, for some parents, the pursuit of another diagnosis, so identifying whether it be ADHD or autism or something along those lines that's potentially related to the epilepsy, can lead to new insights in why their child struggles. It might be that, yes, they have epilepsy, but their main reason why they're struggling is because, or with social skills, for example, is because they have high functioning autism. So in a nutshell, again, this could be a full presentation here, but talking a little bit about special education support, just again, as a primer, so to speak, we have IDEA, which is the Individuals with Disability Education Act. It's a federal law, and that defines and it regulates. So that's the regulatory board for special education. In order to qualify for special education support under IDEA, we need to have a documented disability. Yes, that it would be epilepsy is a great example of one. But we also have to have some special education need that can't be met in the general curriculum or can't be accessed in the general curriculum. So what that essentially means is that if a child has epilepsy, maybe they had, I don't know, a small number of seizures, and the seizures are well controlled, and it's one of those epilepsies that is less likely to be associated with learning or cognitive challenges. And indeed, the child is doing exceedingly well, and the parents are wondering whether special education support would be helpful because the child has epilepsy, and what has to happen is that there needs to be a special education need in order for, so if the child is actually doing really well but has epilepsy, then it's possible that they will not qualify for formal special education. Okay, so school districts do the evaluations called an IEP team evaluation. And let's see here, I want to be mindful of time. In terms of IDEA, we have 13 types of disabilities. We have, there's a speech or language impairment or specific learning disability, intellectual disability, emotional behavioral disability. There's a variety of different what we call categories. Other health impairment is one of the categories, and most often that's considered when a child has epilepsy and again, some associated learning challenges. And special education can be really diverse. It's not just putting a child into a sheltered workshop or in a small group environment. Special education can include some pull out of the general education classroom, can include some inclusion in the general education or the regular education classroom. It can include modifications, accommodations, and supplementary aids and services. And those of you who are familiar with the IEP process, you might be familiar with some of those terms, including supplementary aids and services. And in general, special education is focused on helping children with disabilities to learn in the least restrictive environment. So that's the general idea, is how can we help a child who has a learning struggle access the general education curriculum or as close to the general education curriculum as possible despite their learning challenges. In lieu of special education support or an IEP, one can have a Section 504 or a 504 accommodation plan. And that's based on the Section 504 of the Rehabilitation Act. Essentially, what that is providing access within the general education classroom. These things can include, and so one would have an IEP or a 504. You would not have both, at least you shouldn't have both. It would be an IEP would be special education support, and that could include modifications and supports in under that special education category, or you could have the 504, which could include accommodations and supports, but would not include things like the pull-out or other types of formal special education instruction. And so things that can be included in the 504 sometimes include changes to the environment. So taking a test in a quiet place, allowing the child to sit in the front of the classroom so to eliminate some distractions. There can be some changes to instruction, again, to the general instruction, which would be identifying or helping or modeling key concepts, those kinds of things, or scaffolding learning opportunities for that child. And then the curriculum can be changed in terms of how it's presented, so you can get notes from other kids in the classroom potentially, or getting an outline of the lesson beforehand from the teacher, those kinds of things. And again, to be clear, with a 504, accommodations don't change what a child learns, just how they learn. And the goal is to remove barriers and give kids access to, again, the learning environment. So with that in mind, as a foundation, I'm opening things up to discussion or questions. Again, just as a reminder, kids are with epilepsy are like snowflakes. Everyone's different, so it'll be harder to talk about specifics, your specific child.
Okay, yes, if you have any questions, utilize that chat section. I don't see any yet. I have some questions though, so if you don't mind me starting it off.
Sure, I'm just looking to see. I have a someone thinks it's one chat came through. Okay, got it.
It was me.
Yeah, go ahead.
Okay. Is there a maybe alternative education type or academic type that has been Is there any research about something that's more accessible for individuals with epilepsy, like Montessori or unschooling or anything like that?
That's definitely a good question. As far as I know, the traditional routes of education seem to be, and special education support seem to be the most compelling, especially when considering there's so much variability. So if I were to have a specific child come into my office and their biggest issue was attention and focus and executive functions and motivation and getting on task, I would be least likely or less inclined to recommend something like a Montessori type of education. So it really kind of depends on the child's unique learning strategies and the best route of education for them. Sometimes, there's obviously a benefit to, say, for example, the homeschooling component, because, you could potentially have a child who has seizures, maybe some seizures in the morning, and they can rally, but parents, and rightly so sometimes, don't want their child to go to school that day, but they could actually access home-based instruction or in a homeschooling curriculum. So that could lead to less absenteeism, right? If you have a child who has uncontrolled epilepsy. There's obviously, there's a potential upside to that, and then there's a potential downside. So if a child does more homeschooling and doesn't have social exposure outside of that homeschooling environment, then that's a missed opportunity as well.
Excellent. Okay, we had a question come in too. I'll pitch that to you if you don't mind.
Please.
Is there a minimum effective age to seek out a neuropsychologist for learning?
Ooh, that's a great question. So a minimum, so I would say as it relates to learning, and I would say this with epilepsy and even more generally, and if we're looking at a learning disability, so I'll use like reading disability or dyslexia as an example. Dyslexia, in terms of the definition, is a difficulty with reading and aspects of reading decoding, despite exposure to reading opportunities. So what that means is that if a child hasn't had exposure to reading or mathematics, or has had variable exposure to reading and mathematics. So, unfortunately, different school districts do things at a different pace, or different parts of the country do things at a different pace. And so if the child hasn't had access to learning opportunities, it's hard to assess for a learning disability. So I would say those kids, maybe around first grade, second grade is a good time to start looking into the potential for learning disabilities in a child. So what it means is that, the child has entered formal schooling, is sitting in the classroom with other kids, and, the teacher and or parent are raising some suspicion that particular child is not keeping up with the classroom demands, or is having core issues in those areas that can ultimately impact learning. So I would say early elementary school would be a good time. In terms of the concept, going back to reading, they have those baby Einstein books, and like your baby can read and all those kinds of things. Well, your baby doesn't need to read as part of their kind of developmental level. So to expect a young child to be able to decode, now a very young child can have automatic sight words, so they can see a McDonald's sign on the street and say McDonald's, and they're 3 years old, but they're not decoding. So again, to say that I don't think you need to assess for reading disability and learning disabilities in those much younger kids, in the 4 and 5 year olds. And then the last thing I'll say is that in terms of development and what we call, things like plasticity and the ability for the young child's brain to develop, those ideal times are in elementary school. So on the one end, we want to try to catch learning disabilities not too early, but in elementary school. And we also don't want to miss learning disabilities, because if you have a child who's 15 years old and you've all of a sudden uncovered that they have a learning disability or dyslexia, for example, it's going to be much harder for them to remediate that dyslexia than a younger child, 8, 9, or 10.
Excellent. Okay, so I'm going to this one's a little bit personal, but somebody here has had conflicting information about ADHD or autism. And so what are the similarities and differences between autism and ADHD?
For sure. So autism disorder is essentially deficits in kind of three main areas. The first is in the ability to form and develop relationships. So social reciprocity, the ability to take the perspective that someone else might have and realize that perspective is different from one's own. That's pretty much at the core of autism. So it's the inability to understand or to fully grasp that other people have different thoughts or ideas that might be different than mine. So it's the concept is called theory of mind. So that's the first. The second is problems with communication. So difficulty in using expressive language or even nonverbal language to express thoughts or ideas. So being able to read other people's facial expressions, being able to use facial expressions ourselves, and to have those facial expressions be consistent with how we're feeling. Sometimes kids with autism struggle with that. And also, the ability to use voice inflection to convey a feeling or an underlying thought or idea behind an emotion, like, hey, it's great to be here today, or it's great to be here today. Those are two different feelings, even though the words are the same, and kids with autism struggle with that. So we have, again, social reciprocity, we have communication, and then with kids with autism, we have restricted interest in stereotype behaviors and inflexibility. So stereotype behaviors would be something like staring at objects very closely, or I should say like hand flapping, like looking at a hand like this, or putting your hand like this to your face. Again, stereotype meaning repetitive behaviors that are not functional in any way. And then we have things like restricted interest. So every kid, depending on what we're dealing with now, is TikTok for for slightly older kids, and maybe Roblox for the younger kids. Every kid has their own interest and obsession, so to speak. But kids on the autism spectrum often have these kind of unique and idiosyncratic restricted interests. So being really interested in fans or vacuum cleaners or those kinds of things. And then the last thing would be that inflexibility. So really having difficulty with change in the environment, and kind of transitioning from one thing to the next. So if you think about autism, and then you think about ADHD, which ADHD is kind of a disorder of motivation. It's a disorder of attention. It's a disorder of distractibility. One could see how ADHD symptoms can sometimes look like autism. For example, you have a child who has ADHD who, it's not that they can't take the perspective of mom when mom's really upset that they just threw the fishbowl out the window, but they can't. They struggle with in the moment, because they have ADHD or impulsive, to take the perspective, as opposed to the child who has autism, who really doesn't get the idea that mom's upset. You can see, again, distractibility and those kind of restricted interests. Kids with ADHD who tend to have low attention span are really drawn to things they're very interested in, and therefore have difficulty shifting gears. Kids with autism have difficulty with flexibility and shifting gears. Kids with ADHD have difficulty shifting and changing gears. And you can see how there's some commonalities, but the two are also different in terms of the etiology, or the reason why that they have trouble with X, Y, or Z. So long-winded answer. And I also say that that autism, you can see ADHD and autism as a comorbidity. So children who have autism and who have attention and impulse control problems that are greater than one would expect for the amount of quote unquote autism that they have can be diagnosed with a comorbid ADHD. So you can have both.
And epilepsy.
And epilepsy, for sure.
Excellent. Do you serve young adults age 20 at CHOC?
So if they're a child that can be seen, or a young adult that can be seen by other providers or other specialists at CHOC, then we would be able to see them for sure.
Excellent. Do you have a suggestion for finding a neuropsychologist? Also in speaking with your medical team and about adding this to treatment?
Yeah, so I would say neuropsychology is a small discipline in the sense that I think it represents about I think 3% of all clinical psychologists. And increasingly, we're trying to narrow down the parameters of what defines what a neuropsychologist is. So that can be frustrating to parents because that means that there's less of an obvious, it's going to be harder to find that type of individual. But when you do find that individual, they're going to be more prepared, and they're not going to be just a clinical psychologist who just does testing. So in terms of finding someone, I would say try to find someone who has board certification. There's two main boards. There's ABPP, which is the American Board of Professional Psychology. And then there's ABPDN, American Board of Professional Developmental Neuropsychology, Pediatric and Developmental Neuropsychology. And so I would say try to find someone who's board certified, and you can go on the websites for ABIP and ABPDN to find someone. I'll also say that neuropsychologists, because of our specific training and expertise and with neurological and other types of medical disorders, we tend to congregate around hospitals or hospital environments. So it's going to be harder to find a neuropsychologist in the community, easier to find one in a hospital type setting. And then the other part of that was, and speaking with the medical team about this treatment, I would say at least in Orange County, the vast majority of neurologists in general, and certainly I would think all the epileptologists are very familiar with the concept of neuropsychology. So how I would bring it up to someone is, well, I would find that you just bring up, hey, my child seems to be learning, or, she seems to be struggling with attention or memory. I wonder if they have, I know that kids with epilepsy can have problems with thinking and learning. What do you think about doing a neuropsych evaluation, or how can I get support that, might be, or get a clearer picture of what's going on that might be better than what the school can provide? Because keep in mind, the school is providing an evaluation to determine whether a child qualifies or not. They're not trying to find out how your child learns best.
Yeah. Excellent. Yes. I kind of want to tack a question onto one of these really quick before the other one. At least locally, do you know if the adult epilepsy centers do offer neuropsychology the way that you guys do?
I know UCI does.
Yeah, because they can work with 14 and older. I know there, so maybe that's why. Yeah, but
so, yeah,
is there benefit of having neuropsychology with the adult patients like that? Like you said.
Yeah, I'm glad I was just gonna add that little piece. The way I look at it is, if your child/young adult has, and you have concerns and they have concerns, or things that are school related. So if a child is 20 years old and is starting college, or 20 years old and starting graduate school, and they're struggling with aspects of learning and processing that way, then I think pediatric neuropsychologists would be great, because we work under the, considering the broader umbrella of learning and functioning in the classroom or the school setting. So if it's a school-related referral, I would say, and they're 19 years old, I would see a pediatric neuropsychologist. If the young adult is an adult and is independent, and there's concerns for maybe something that's a little bit more kind of daily living, like money management or something along those lines, then you could certainly do an adult neuropsychological evaluation, which they tend to be a little bit shorter and a little bit more more global. At least that's been my experience.
Gotcha. Okay, here's back to this question. Can you give an example of what type of recommendations you and other neuropsychologists give to children with epilepsy and intellectual disabilities?
Yeah, again, I try to be pretty targeted. I find that those broad recommendations that you kind of throw out, those kind of canned recommendations that the school hears about all the time, I try to be use them very sparingly, because I often see other reports. I'm a ABIP board certified reviewer for other folks who are looking into board certification. And sometimes I see 20 recommendations in reports, and a lot of them are generic recommendations. So I can give you some ideas for generic recommendations, but I really think the focus should be on the individually tailored recommendations. So, for example, if I evaluate a kiddo who doesn't have like ADHD, but has some attention problems. And we find that those attention problems tend to occur closer to 1 o'clock in the afternoon, because I test throughout a day, and I can test in the morning and the afternoon. Maybe focus more of the curriculum in the mid-morning, or if they're in high school, load up the core academic areas in the morning and try to find more peripheral things in the afternoon, like PE or something like that, when attention is waning. Those kinds of recommendations. Trying to think of another one that I would give that's a little bit more tailored, but also can be used generically. Yeah, again, the front of the classroom, or having the teacher, check in with Sally at the end of explaining something, or maybe Jimmy struggles with kind of getting started. So maybe peer Jimmy up, or pair Jimmy up with a peer who is, a more of an independent / mature student who can kind of guide them, through an activity. In terms of the intellectual disability piece, the conversations I often have are, at some point you have a general education curriculum that focuses on teaching algebra, and then trigonometry, and then pre-calculus and calculus, and et cetera, et cetera, et cetera. And then you have a curriculum that's teaching more of a daily living skills and functional skills, how to keep a bank account, how to understand kind of safety issues, how to make meals, how to understand functional mathematics. Like I have a recipe here, and I want to have the recipe. So how much flour does that mean instead? And so again, those are two different tracks. So with a child with an intellectual disability, the question comes is, well, are they going to be on that algebra, trigonometry, pre-calculus, and calculus track? And is that going to be helpful for them when they're older? Or are they going to be more better suited to, or derive more benefit from one of those functional tracks? And so having recommendations about that. So maybe a little bit of pulling, because, Sally is really enjoys mathematics and is making some great progress. So maybe she can be pulled into a special education math class, but maybe forego some language arts because we have language-based issues, and focus most on health and safety and those kinds of things. So those would be some of the recommendations.
Excellent. This next question is a little bit specific, so I am going to edit this one down a little bit, but it looks like they're asking a question specifically about learning strategies for memory deficits, especially short-term memory issues. If there's any strategies specifically for that, which I think you touched on a little bit, but.
Yeah, so the idea is, when you think of memory, it's kind of like what I was talking about with writing. Like, memory is a process. So if I were to read a list of words to you and I read them too quickly, and I said, hey, like 30 minutes later, do you remember those words? And you didn't remember those words, it's not because you have a memory problem, it's because it was presented too quickly for you. Or if I, gave you a list of words in the middle of like a construction zone, and, there's a lot of things going on, and, you couldn't pay attention. You were distracted by other noises and other sounds. And then 30 minutes later, I said, hey, do you remember these words? And you didn't remember them. That's not a memory problem. That was a distractibility problem. And so the idea behind, say, for example, working or short-term memory, I love the term working memory, again, keeping information in mind to process, is try to find where the breakdown is for your child. Is it that you gave them too many steps? Is it the material was too tricky for them and it was too hard to digest? Or did you jump around to a variety of different things and you didn't spend too much time on one thing? Or is it purely a distractibility issue? Or is it purely a processing speed issue? So those strategies for working memory or memory are pretty varied, but it also kind of depends on what the problem is and where the breakdown is. There are some books on memory strategies. Indeed, they're usually geared towards adults, but you can find memory strategies for kids on Amazon or those types of books. But again, I'd like to, and you don't need a neuropsychologist necessarily to figure some of this stuff out. You can be kind of the scientist practitioner yourselves, and again, try to examine where that breakdown is. Why doesn't it stick for Sally? And try different things or different strategies. Using a memory book as a reference for those strategies, and just see what works. And if it is a big deal or becomes impairing or negatively impacts day-to-day functioning to a significant degree, that's when you talk to your neurologist about making a referral.
Excellent. Have you worked with children? This is kind of a specific one as well, but have you worked with children with both generalized seizures and PNES? Is this pretty uncommon to be diagnosed in a child? Do you have recommendations in explaining this to school staff or others in the child's life?
Yeah, so I would say, generalized seizures. So both generalized seizures and PNES. Yeah, that's a tricky one. I think that your best bet is to find a therapist, psychologist who is familiar with PNES, who can work with your child and find kind of the unique, because sometimes it can be very difficult to distinguish between a generalized seizure and something like PNES, and like what seizure is more in the realm of epileptic versus non-epileptic. So that's a tough one. Without going in very deeply into the weeds, it really depends on the child's specific situation. But what I would do is I would get an advocate to help the school understand, and that advocate can start out by can be the therapist or the psychologist. It doesn't have to be like a special education advocate, because they're probably not aware of those two things. Yeah, I mean, that's obviously a tricky one. That's a tough question.
Yes. Okay. That seems to be most of the questions so far. If anybody else has questions, please put them up there. They've been great so far. I'm so glad I was able to attend this one, Dr. Romain. I have learned so much. And this is what I do all day, is help support these people. So I really do appreciate that. We have another, thank you so much, super helpful comment.
Yeah.
Any other questions to add on? Okay, so just to clarify, I guess that I am more familiar professionally with you guys at CHOC, the child psychology side of this. You guys mainly are directed toward academic skills, correct? Not, do you also work with life skills or anything like that? I know you touched on it, but.
Yeah, so we definitely evaluate life skills. In terms of the treatment portion, I would say most neuropsychologists provide more of that assessment. We spend more time figuring out kind of what is the breakdown, what's going on, and why does this child have a memory problem? Why does this child have a reading problem or a writing problem? And we figure out what that is and then make recommendations for that. And then in terms of the treatment or the support, and a psychosocial variable could be one of them, like, hey, your child doesn't have ADHD, they have anxiety, then we make recommendation for psychotherapy to help with that. Or back to the school for special education.
Awesome. Ooh, another question popped in. How is learning affected by seizures in the vision area of the brain?
So that's a great question. So when you think of seizures or epilepsy coming from a primary visual cortex, which would be the occipital lobe, you can see a variety of things or nothing that really directly affects learning. In fact, I would say that, I've definitely seen kids who have occipital seizure focus. And usually when I see them, it's their seizures are emanating from the occipital or the primary visual cortex. They start there, but they secondary generalize to the rest of the brain. Sometimes you can see, visual disturbances. I don't know how that would be necessarily impacting learning, other than it could certainly be distracting. You can, I guess, potentially you could see some visual field cuts. I would say it's not something that I see super often in terms of just pure learning difficulties in the context of a primary visual cortex epilepsy. If there is a neurologist or epileptologist speaking about specific types of epilepsies as part of this awareness day, I would definitely try to ask that question to them.
Excellent. Does it affect reading?
No. So vision is, so the idea of reading disability being a primary visual problem is actually not accurate. A reading disability or traditional developmental dyslexia is a disorder of phonological processing or phonological awareness. So it's the ability or inability to process phonemes or basic words. So Rachel, I'll use you as an example. So say baseball.
Baseball.
Now say baseball without saying ball.
Base.
Say spider.
Spider.
Now say spider without saying der.
Spy.
Good. Say powder.
Powder.
Now say powder without saying d.
Power.
Good. So what that is, it's that Rachel seems to have intact phonological awareness. She can segment speech sounds, by hearing them and hearing the difference. That is at the core of developmental reading disability. Now, you often hear things are switched backwards and upside down, and letter transposition is a common term. That's just an artifact, because a letter D, which is a ball with a line on it, is D, and a letter B is a ball with a line on the other end, and it goes B. And if you can't distinguish between the D and the B, that's kind of at the core of a developmental reading disability. So it's not a vision problem. And so therefore, I would not expect to see a disproportionate number of reading disability patients with occipital or primary visual cortex epilepsy.
Excellent. While we were talking, so many questions came in. So we're running close to time, but if you don't mind hitting as many as possible. For a nonverbal student, how can you assess with autism or apraxia? What are the typically written off? Are they typically written off as intellectual disabilities?
Yeah, so maybe historically they have been written off, but there are definitely ways that we can assess. I think the other thing too is, so there are nonverbal measures and other types of avenues to access, how the child thinks and learns and processes. But sometimes you get in a situation if a child is nonverbal. So being nonverbal is not as much of an issue, but if a child is nonverbal and also has pretty severe autism, their ability to kind of relate in an environment for testing can be really tricky. So sometimes it's providing education and then also hearing the story about where the child is super successful, and then writing as part of our report, if we can't do a lot of formal testing, to highlight, hey, it's not don't over assume that this child has an intellectual disability. They have problems being able to communicate. And so, these are things that we found that could be helpful based on our evaluation. So yes, absolutely don't write these kiddos off, but at the same time, be aware that sometimes standardized administration is going to be tricky to do.
Interesting. What is the earliest age that ADHD or an intellectual disability can be diagnosed?
So, in terms of the diagnosis of ADHD, I think it's in part clinician specific, or, I've definitely seen some psychiatrists diagnose kiddos as young as 3 or 4. I have definitely seen kids who very much have impulse control issues and hyperactivity that is greater than expected from their developmental level. So I would say if it's easy to differentiate between the child's developmental level and the degree of difficulty they're having, then one can make the diagnosis. As it relates to intellectual disability, I would call it a developmental disability first, because that means that, hey, we're still in a very early process of developing and growing, and we're not going to say someone has an intellectual disability very, very early on in that process.
Okay. Do neuropsychologists diagnose auditory, visual, or other processing disorders?
Typically, we don't do a lot of auditory processing disorder evaluations. Speech pathologists do that, but just be careful with those, because sometimes things like ADHD can be masked as an auditory processing disorder.
Excellent. And then, is it common for some kids to be advanced in reading but have difficulties organizing thoughts for writing?
Absolutely.
Excellent. Okay, we are over time, but that was excellent. Thank you so much, Dr. Romain. And if you have any questions about CHOC or how to see amazing doctors, if you guys are local, you can always check out our organization. We help a lot of people get referrals, and a lot of the patients that Dr. Romain sees are also our members. And so we are mutually helpful in that way. I actually just saw a member forwarded one of your reports to us because they wanted us to look at it too. And it is amazing. I loved it. So thank you so much for joining.
You're welcome.
they're on to the next doctor. You guys have a great expo day.